Donaldson, the chair of the Integrated Care Board for North East and North Cumbria, and this section of our business today is being held in public, and it's our annual general meeting where we're going to highlight items from our annual report for the year 2024-2025, and which is then going into the public domain. Some members of the public in attendance, I would like to welcome them to the meeting. In particular, I'd like to highlight the attendance of Alan Foster, who many of you will know worked with me as Chief Executive when the integrated care system arrangements were in shadow form. This was even before we had a Chief Executive. So welcome to Alan, and you can see some of the fruits of his early labour coming through in the changes that have happened since. I'd like to just highlight a few points from my introduction to the report, and then I'm going to hand over to our Chief Executive, Sam Allen, to present her reflections on 2024-25. Now, we've got a few slides just to summarise what we're saying, but I think first of all my initial comment is to express my thanks to everyone who has played such a big part in helping the Integrated Care Board and the integrated healthcare system for North East and North Cumbria to reach the point that it has. It's been a very big period of change, as you all know. A new government was elected during our tenure, and we've got a range of reviews and policies and new priorities that have been set, and we'll say a little bit about that in a moment. We've also been asked to make savings from management costs and put those out into frontline patient care. We've already done some of that work, and some more changes of that nature are pending. And that, of course, isn't just affecting anonymous budgets. It's affecting real people who whose jobs will be at risk in the process, and so we're working very hard to support staff through what's quite a difficult change process. But we've also a new plan, the 10-year health plan, which has attracted great interest and great attention. And having been in the business of formulating health strategies for over 30 years now, what I like about this one is its simplicity. Sometimes you produce strategic plans which are highly detailed with pages and pages of actions that have got to be taken. But I've always felt it's much better to create broad goals which then can be implemented in different ways in different places depending on local views and on the context, which is very different around the country. And these three shifts in the way that the health and care system does business are really important areas, particularly in the North East and North Cumbria. The shift from treatment to prevention is the first of the shifts, and with our very high levels of premature mortality and our high burden of disease in fields like cancer, heart disease, respiratory disease, means that it's particularly important for us to get deeply into this agenda as quickly as we can. Of course, we've already done traditionally a lot of work in this area, but sometimes the outcomes that we want to see, the improvements in mortality, the reductions in inequalities, and the lowering of the chances of developing one of these diseases which are incapacitating, disabling, and often life-limiting. Making the change visible so it matters to people, but also in the measures that we look at has proved very, very difficult and stubborn and resistant to change in the past. So determined this time around to really put in place actions and implementation that will make that shift a reality, and that will be very, very beneficial for the health record of the North East. The second shift on hospital to community, it's coming on its own, I would say, because it links very strongly to the third objective, which was the move from analog to digital. Because what's traditionally happened in healthcare and medicine is that technology, science, innovation change things in a way that means that hospital stays are no longer the 10, 14, 20 days for routine conditions that I used to have to look after patients for when I was a medical student and a doctor in training. The idea of a day case surgery, for example, when I qualified would be unheard of, and the idea that you could have your gallbladder taken out and go home on the same day. Equally, when in those days I treated people with coronary heart disease, there was nothing that could be done apart from put them in a bed and give them pain relief. A quarter of people died in the street or at home before they came in. Another quarter died in the first 2 weeks in hospital, and another proportion died slightly later. But basically, those were predictable numbers of deaths from a condition which today can be dealt with, giving very high levels of survival due to modern technology and drugs and the skill and commitment and ability of the teams working in our services in the North East and North Cumbria, and indeed other parts of the country. So those changes it won't be easy to make the shift from hospital to community, but